I am Cheri Fry. I'm excited to be hosting is this the second? I believe this is the second virtual networking event. Before we get into our lively conversation, I do want to take a minute to thank Pfizer, especially, who has been such a great sponsor for us. And I'm actually going to let Jim Rigby, who is with Pfizer, speak for just a couple of minutes to you all.
Let me get unmuted.
You're good.
Can you hear me now? Okay, great. Hi, everyone. How are you?
Good.
Yeah, thanks for letting me take a minute or two here. I like doing these meetings in person. I've been to a number of Skin of Color Society meetings and networking meetings. We've sponsored this now. This is our third year, I believe, that we've sponsored these networking meetings, and I've been to a number of them. They are more fun in person, but we adapt, right, and do our best. I'm super proud of what we do at Pfizer and our association with the Skin of Color Society, with the annual meeting, with Media Day, which I attended last year in Manhattan, and just our continued collaboration across the board. Within dermatology, we plan to be here a while. And because of just great people in your organization, like Candace Heath, I see you out there, Dr. Heath, how are you? We've just, I don't know, I think garnered such a great partnership, and I'm just looking forward to many years to come, and hoping in 21 we can get together in person and do a couple of these events. But looking forward to listening to you all and offering this opportunity for you all to get together and discuss interesting topics in your specialty. So thank you so much for giving me the time. Kimberly, thank you for helping me with all the logistics and getting this thing going, and hoping we can do some more virtual ones too prior to the end of the year. So I'll sit back and let you guys do your thing. Thanks again for giving me a couple minutes.
Thank you, Jim, and thank you and Pfizer for your continued support. We appreciate it. All right, so I hope everybody is excited about our conversation for today. We've already gotten a ton of feedback. So I know that we're gonna have a lively and spirited conversation. Just a few housekeeping things before we get started. This is an open dialogue, so I am simply the moderator. I'm gonna begin with a little bit of background information, but I want you all to feel free to participate, and you can do that one of two ways. There's a chat box if you're not familiar with Zoom, although I think that would be impossible by this point. But if you're not, there is a chat box at the bottom of your screen. Feel free to go in and type questions. There will also be some resources there with links to different things that we discuss. And then you're also welcome to unmute yourself if there's a comment that you want to make. So everyone will be free to speak throughout this discussion. But we ask that if there's a lot of background noise and things going on, just go ahead and mute it so that we can hear each other. And I'm excited to dive into our discussion today. So we're going to begin by just talking about this changing landscape in medicine in general, and then we'll be more specific to dermatology. But we have, of course, our board certified dermatologists, but today we're going to be talking about mid-level providers in dermatology. And so we're specifically talking about nurse practitioners and physician assistants. And we already got feedback on the term mid-level. And so we'll be diving into the discussion about that particular name in just a moment. But I want to go back in history a little bit. So if we think about the period in 1965, there was a lot going on. We had soldiers returning from war. This was sort of the baby boomer generation. So we had a lot of children and families were expanding. We also had the Medicare and Medicaid Act, which was signed by President Johnson. And this provided an additional healthcare coverage to about 19 million Americans. So more people than before had access to healthcare. And we were encouraging people to start their journey with a primary care physician, and then they would decide on specialists. Physicians were in record numbers specializing in medicine, just with technology and advancements in science. So we really had a growing population, and the demand for physicians was unfortunately outpacing the supply that we had. And so two groups emerged to help with meeting the needs of the people. And so down in Duke, we had the first physician assistant program, which was developed. And the thought behind this was there were some already very experienced medics and corpsmen in our military. And they had seen action and taken care of patients on the battlefields. They had sort of an expedited training during World War II, in order to be able to take care of the wounded. So with the need for more healthcare and clinicians, Dr. Steed down in Duke said, let's take these corpsmen who had years and years of training, and let's sort of put them through an expedited program. And this is how the physician assistant program was developed in Duke. And so it was a 2-year program, master's level degree. And Dr. Stead really was doing this to improve the primary care workplace and to extend that care to more people. But again, most of the graduates, at least early on, were coming out of our military with already having some background in medicine. The other group that emerged has come to be known as our nurse practitioners. And so these are masters and then went on to earn doctorates in nursing. And the first program was at the University of Colorado. And so there were nurses who worked side by side with physicians who had a lot of experience. And again, to kind of fill this gap with all of the patients that needed the services of a physician, they developed a program to help educate nurses further in order to get them into our sort of clinician role. So these are our two groups. And like I said, initially it was there to really improve primary care and to expand the primary care workforce. But as medicine does, things sort of advanced. And now we see that both physician assistants and nurse practitioners are joining the ranks of specialty medicine. And so when it comes to dermatology, we know that there are not a lot of dermatologists, around 9,000 dermatologists practicing in the United States. And so now we have a lot of physician assistants and nurse practitioners who have joined with us in dermatology, and they're utilized in different ways. So we're going to talk a little bit about how they are being used. As nurse practitioners are gaining full practice authority, they have full practice authority in 23 states now. And physician assistants are also, lobbying for more independence. A lot of questions arise. And so some of those questions we're going to talk about today. The first thing I want to talk about, though, is the one that I think people get a little bit sensitive to, and that is just the term mid-level. We have to understand where it came from. So the FDA, when talking about the dispensing of medicine, in its statutes, it refers to physician assistants and nurse practitioners as mid-levels. Now, some people have an issue with that because they think that it has a negative connotation, and patients may think that they are getting inadequate care. So I want to first start with that discussion here. I'm going to open the floor up to anybody who wants to chime in.
Hi everyone, my name is David. I'm a medical student. I was I'm sorry if there's someone else going. I was just curious. I haven't heard very many alternatives to the like phrase mid-level, and I was just curious what they are and if they exist.
So that's a great question. So I think the term that is emerging, especially from our nurse practitioners, is advanced practice provider. So that's one. And then we've heard terms like non-physician clinician or non-physician provider as well. But the new term that I think that they're suggesting is advanced practice.
My question would be advanced from what? I don't understand why that term, where that comes from. Like, how is that better or more descriptive than saying mid-level or nurse practitioner?
I think advanced is misleading, right? Because we don't say advanced physician. So as soon as you say advanced, you assume that it's like superior, better than, greater than. And for patients who don't really know the difference between different types of clinician, adding the word advanced makes them think, oh, okay, that's the top level.
Exactly, Chisana. That's what I'm saying. Like, advanced from what? Like,
Yeah.
what is the basis?
Yeah.
It's just confusing. It's already confusing. And now we're confusing it even more.
Mm-hmm.
And Cheri, you said something when you were speaking about that, you know, nurse practitioners have doctorates in nursing. And most nurse practitioners do not have a doctorate in nursing. They are master's level. And now there is an additional doctoral degree in nursing, which I need help understanding that one too. But, you know, to each his own, but it's just muddying the waters. And I've just yet to see a curriculum that rivals the rigorous journey that physicians undertake to get to the point to which we have all gotten to.
Could I please echo that? I completely agree with, I'm sorry, whoever was just speaking, that I find that term completely misleading. Advanced to what? And I also completely agree that the rigor of medical school doesn't even come close to anything else that is there. And I just wanted to agree with whoever just spoke.
Yeah, I believe that was Corey that was speaking, and Shoshana chimed in as well.
I was muted. Sorry. Yeah, I'm Corey Hartman. I am a board certified dermatologist practicing in Birmingham, Alabama. And I actually serve as the co-chair of the membership committee for the Skin of Color Society. But yeah, that was me speaking. And maybe everybody can kind of introduce themselves so we know who's who.
Yeah, if you want to make a comment, just use that opportunity to introduce yourself. But the question that was on the floor here is the use of the term mid-level provider, which, like I said, actually arose from the FDA statutes talking about prescribing, and that's where it originated. And so we are now being informed by our nurse practitioners that the preferred term is advanced practice providers. And then some of the physician assistants, which in some instances are actually vying to have that name change as well from physician assistant to physician associate.
I'm Cather McKay. I'm in practice in near Destin, Florida, Fort Walton Beach. I have a problem with the term provider, and I think that a lot of mid-levels, like, that's the term that they prefer for just to put everybody in the same bucket. And provider, it's like bringing us down a notch to put us all on the same level. And it makes it easy, you know, and like nurses, whoever's answering the phone, call us providers. But, you know, that kind of, I don't like that term. And I think I find myself accidentally saying it sometimes and try to catch myself. And, but that's another thing. I feel like it's insurance and just, you know, it's becoming a term that puts us all together, which maybe mid-levels like that, but as a physician, it's a little bit, a ding sometimes.
I 100% agree with you. I have 2 nurse practitioners in my practice and 2 physicians, and my, staff they will use that term. It's easier than saying, physicians and nurse practitioners, but I always make it a point to say MDs and NPs. That's short. We can do that because the more that we allow them to muddy the waters, the more that the distinction between our levels of training and our abilities becomes more difficult for the public to understand, as they are. So, are there any mid-levels on the call?
They're surely welcome. So I'm sure
of course they were welcome.
Probably have a couple on there.
And that's fine. I really want to hear the feedback on why topic. Because as soon as we put the announcement out, I've posted on Instagram before and said the term mid-level, and they try to come for you about it. And I just want to understand, like, where does that animosity come from? Like, I just don't understand. So I was hoping that some of them, I know that some requested to be on, and I wanted to get some dialogue going, so maybe I can understand better where this, I was shocked at how strongly this was a sentiment on the part of the nurse practitioners and other mid-levels.
I was also curious. I'm sorry, go ahead.
Okay, sorry guys. So my name is Kaz. I'm a dermatology resident at Emory. I also serve as a co-chair for national and international committee at the Skin of Color Society. So I'm originally from Ethiopia, so I practiced there, and I also trained mid-level providers before I moved here. Basically, the mid-level provider is actually the preferred term internationally. And if you see the WHO guidelines, actually you can classify healthcare providers as low-level who just got training, maybe 1 year, 10 months training after high school. And those typically do like vaccines and preventive medicine. Then you have what we call the mid-level, which might sometimes be called as health officers or physician substitutes. So they can provide some basic prescriptions as whenever there are in areas where there are physician shortage. Then we have high-level providers, which includes physicians and surgeons. So I also see that advanced practice provider, I don't know what that APP, it doesn't really fit well for most patients when we talk, what's advanced, and it looks actually superior than a physician provider. So either we have to use the term non-physician provider, physician substitutes, whenever there are in areas where there is a physician shortage. But at the same time, I just would like to acknowledge that they provide really good care to some patients, and not all skin diseases require physicians, to be honest. We also asked a question that the United States is the richest country. We have lots of money. We spend like $10,000 per person for healthcare. So there should be a way to give an advanced care. So anybody who would like to be seen, who have any skin rash, or who may think that they've got melanoma, would like to be seen by a dermatologist, not by a non-dermatology physician even. So there is a question that whether if we really need physician substitutes in the US, is that not easier maybe to train more dermatologists, because we can afford, to be honest. So this is a question that's raised. So overall, mid-level providers and physician substitutes are very, very helpful for developing countries and for other countries where there are significant economic burden and physician shortage, but I doubt really if that we have to continue training physician substitutes in the US.
Thank you for that comment. That was excellent and I think very insightful. I have a separate question about the training of dermatologists, so I'm going to ask you to hold that point just for a second, but I love your feedback and it's great to hear what's going on in other countries as well.
Thank you.
Anyone else with a comment? We're talking about the term mid-level provider, and you said physician substitute. Ooh, I'd like to see that one fly. I don't know how that one would do in the US, but any other comments on the terminology? And I would love to hear, just like Corey said, I have a physician assistant who is wonderful that I work with in my office. And I am absolutely for a team-based approach. So if there are any physician assistants or nurse practitioners on the line, I do not want you to feel attacked or unwelcome. This is an open dialogue. And I think this is a safe space for you to be able to talk, because in order for, maybe there are things that we're not seeing, maybe there are experiences that you've had that you want to talk to us about. So I'm really interested if there are any PAs or MPs on, if they want to comment on this.
And I was just gonna say before.
Oh yeah, sorry.
I'm sorry about that.
No, go ahead.
My internet connection is a little choppy. I'm in a hotel during rotations, but I think at least like the nursing field is kind of like revamping itself right now and kind of like redefining itself. I've seen that a lot of programs are switching to that DNP, that doctor or nurse practitioner. But right now, nurse practitioners can kind of be like grandfathered in with just a master's degree. But I think that'll start switching sometime around, like, I think it was 2023 or 2025 or something. And so going forward, I guess it'll be like nurse practitioners that will also having people refer to them as like, oh, I'm doctor so-and-so, but really just like not just, but really that person is somebody who has a doctor's or nurse practitioner. And so it is kind of interesting that there's kind of like this revamping going on in the field. And I think that it might be helpful if maybe there is like more of these conversations, especially from like, like the physician side coming in and being like, okay, well, like at what point in our field can somebody establish an independent practice? Like, what kind of education do you need to have? Like, it's definitely true that we want to increase access to for dermatologic conditions. And there are some diseases that can be treated without having like the full MD attending like knowledge. But there's definitely a lot of stuff in the field of dermatology. I don't need to tell you all that, but that there exists. So like, there's definitely stuff that, we eventually will know that others want more clarification on. So yeah, I guess maybe there might be a point of like potentially even like the dermatology groups just kind of trying to go and like have these discussions in the future or now even.
I didn't know that, what you just said. So it sounds like they're trying to do what the pharmacist did, where it used to just be an RPH. I think did they even add a year maybe? And now it's a doctor of pharmacy. And I want y'all to know that all this stuff has real world implications. It's not just nomenclature and status and clout. The Louisiana Board of Medical, the Louisiana Derm Society just had to go and fight the lobbyists for the pharmacist group in Louisiana because they thought that they should have the ability to just treat acne and shingles. So that's where it starts. Here in Alabama, where we are proudly the only state where mid-levels cannot inject Botox or anything else, they have a group here called, and Cheri, look, just stop me if I start talking too much, but there's a group they call themselves the Society of Dermatology Professionals, Alabama Society of Dermatology Professionals, right? They are nurse practitioners and PAs When we saw this coming, Alabama Derm Society went to them and tried to envelop them under our wing because, you know, we figured there was some reason that they were doing this, and there was. They rejected our offer to become a part of the Alabama Derm Society as, you know, special sort of members. They formed their own group. They went to the board. The board saw this Society of Derm Professionals, thought it was us, and thought that we were sanctioning and endorsing them to be able to inject Botox, initiate biologics without a physician approval. And it was this big mess, and it got shut down. But those are the kinds of things that matter when they seek these different you know, classifications. So it really does matter. I didn't realize that they were doing that. Sorry.
Any other comments on the nomenclature? Okay. Sadly, we didn't hear from any of our PAs or MPs, so I really hope that you'll speak up, because we definitely want to hear from you. So I'll move on to my second question. As I discussed, you know, California was the state that most recently gave full practice authority to nurse practitioners. Now, let's remember that physician assistants, their training is modeled after medical school. It's an abbreviated or master's level program, and they are governed by the Board of Medicine. However, nurse practitioners are not. They're governed by the Board of Nursing, which means that, you know, boards of medicine, we have no say in a lot of their education, their curriculums, their certification, and certainly not any disciplinary action. Because they are not considered to be practicing medicine, also things like malpractice insurance, even malpractice claims, they're usually going after the physicians or the hospitals when they are in supervising roles or collaborative roles. So 23 states and DC now give full practice authority to our nurse practitioners. And that has, you know, implications in dermatology, because in other specialties, but it means more to us in dermatology, because in large numbers, we see nurse practitioners opening up dermatology offices and providing dermatology services. And they are not residency trained. They do not have to pass a dermatology board exam. So the training is just not there. And we're talking about them doing some of the things that Corey mentioned, but also seeing patients with potential melanomas and things of that nature. I just wanted to pause and just read the American Academy of Dermatology, just a small portion of their position statement. And they clearly state that their position is that non-physician clinicians cannot appropriately provide care in independent dermatology practices. So we say this for full practice authority states for nurse practitioners, but also because we know that the states they vary greatly in the amount of supervision that is required for our physician assistants. So as I stated, I have a physician assistant, wonderful, she's excellent. She's in the office with me. It's just the two of us in that office. But we all hear or have seen offices where physician assistants are supervised by physicians that are states away, or, you know, barely supervised at all. That definition of supervised is very loose. So the look of dermatology and the dermatology office, especially when you lump everybody together as a provider, you don't necessarily know as a layperson when you're going in the level of training, especially if it's an office, you know, with, you know, let's say Mike Harris, NP, dermatology office. You may go in thinking that you're seeing a dermatologist, and especially if that person has a doctorate in nursing, they may refer to themselves as Dr. Harris. And so patients a lot of the times don't know. So my question is about this independent practice, both full practice authority for nurse practitioners who are seeing patients for dermatologic needs, and then the supervision, you know, collaborative relationship between physician assistants and our dermatologists. These have a lot of real world implications. We know dermatology is a very tasty field because we do have things like filler and Botox, and so it can be lucrative, but it can also just be very exciting to be in that field. So I'm going to pause here and open up the discussion. Okay, let me start with this. So Corey already said that he has nurse practitioners that he works with. I work with physician assistant. Do you all work with nurse practitioner, physician assistants for our residents? Do you have them in your academic institutions? How has that impacted you?
But I guess only out of silence, I'm a solo practitioner. I don't have a PA or a mid-level, but I am drowning in volume and I don't have room for another dermatologist, right? Like they wouldn't have an office. I have no idea where they would sit down, right? And I'd use up all 4 rooms all day long. And I almost feel like it would be an insult to have a board certified derm in my office until we move into a new building, which isn't going to happen for another year. So I'm struggling with, I need help, but I am currently not in a position for getting a full-blown dermatologist just yet. So if I wasn't worried about the slippery slope, right? What do they call it? Scope creep. Then I would have gotten a mid-level when I needed one a year and a half ago. So I'm really curious. I mean, unless someone, you know, has another comment, like what's the balance with having a mid-level to serve the purpose of their role, which is what I think is like a position like mine, but not abuse it and cause the issues we're having currently.
So I feel for you and I've been in your position, and just please do understand that it's one of those things that once you started, there is no going back. So, I mean, you're busy, right? You have control over what you see and what you can't see, and you do the best that you can. I mean, I think that we try to put too much on ourselves, and if that's your capacity and you have 4 rooms, then wait until you can have a doctor. I don't think that there's a reason to rush into it. It's not, you know, you're not the reason that people can't see dermatologists. You're doing everything that you can and you're at capacity. So keep doing that and let the residency programs deal with the fact that there's a shortage in your area. You know, I mean, I know you want to do well and you know, not do well, but I know you want to help the community because I know your heart and I know the kind of person that you are, but that's not your burden to carry. And so if it's going to risk you being in a position, I don't know what the situation is in Maryland. Can they practice independently?
Yes.
So yeah, so you train them, just like the one that happened to me, the PA, who led this, or who, she's not with my office anymore, but she ended up being the PA who started this group, who moved from a different state where they had more rights and has a chip on her shoulder. And now she's, you know, she left after 2 years, right after the cutoff was to return the signing bonus, and, you know, went to a different practice. She can't practice independently, but that's what would happen in a state where she could. They learn everything that we are paid pennies to learn for 3 years and actually have to master it and take an exam. They learn on your dime, making $100,000 a year, and then take the best offer when they feel like they have enough training. So I say this all the time, because that board certified dermatology group, you know, is a toxic environment that I do not like. But people go on there and want to bitch and complain about, you know, how mid-levels are taken over. But when you start looking at it, they're the ones who employ and train the mid-levels. So, I mean, we're doing it to ourselves. So until we decide that we're not going to do it, then, you know, it's going to continue to be a problem. So I feel somewhat insulated here because they have so few rights, and I know that they don't have that ability. And, you know, that's one advantage of being in a conservative state. But, you know, the day that comes that they can practice independently, I mean, all bets are off.
And I think it's important as we talk about this, because I think the discussion that a lot of other groups are having is, oh, when it comes to us, it's all ego, and, you know, we want to be the only ones to treat patients, or we want to be the only ones to inject, or we want to be the only ones to, you know, earn high incomes. But I know personally that most of the dermatologists I know, that's not the concern. That's not the concern at all. You know, there's enough pie for everybody to eat, but the truth of the matter is there is a big difference in the training, and that goes all the way back to medical school, residency. You know, there's a huge gap in training. And so, like I said, I am for a team-based approach. I really hate the fact that we're having this scope creep and that these discussions even need to come up, because for you, Dr. Kendra, I mean, that would be a great opportunity for you to bring on a physician extender, right? So if you had somebody there who could, you know, you could diagnose, and, you know, if somebody just needed, you know, some follow-ups, you could have that physician extender see those patients. Or if somebody had something acute, you can get them in, or they can do technical things for you. I mean, it's a great role, because I think physician extenders, they meet a great need. But the problem is we are now reluctant to bring them into the role that they were designed for.
Exactly.
Because we have to be concerned about what their next step is. And who loses when that happens? The patients lose, because there are patients that need to see you. There are patients that are desperate to see you, and now they're going to have to wait 3-4 months, and it all comes back to this point. So
can I just add a point here? Okay, the role of PAs and NPs was to extend care into areas that were underserved. A PA is now more likely than a physician leaving medical school to specialize than a physician. Like, they're more likely to specialize than a physician. They're more likely to practice in an urban area than a physician. So this whole experiment has failed.
Well, fail for who? It's worked out really well. And we have these other conversations about, and this is where I want to kind of get into the next question, and it's really how it's impacting the next generation of our physicians and dermatologists. Because now, if, you know, our residents that are coming out are being, in some instances, forced to supervise mid-level providers, or maybe they're not comfortable, or if they're having to compete in residency with nurse practitioners and physician's assistants for patients, for cases, you know, that's going to impact their training. And then what are we looking at 10 years, 15 years down the road? You know, what can we expect dermatology as a specialty to look like? So it's not just for the here and now, but it's for the future, because we've had a conversation. I've had colleagues that said people are thinking about not going into dermatology because it's so flooded with NPs and PAs. So that is a huge concern, just like I said, for the future of our specialty.
Yeah, I don't want to sound cynical, but, you know, as a medical student, it almost sounds like, well, why am I here if I could achieve the same goal just going this other route, which is like much cheaper. I don't want to be offensive, a lot shorter, and it's less, I don't want to like start anything, but like less, it's just not as rigorous as med school, to be real. Like, and so.
Keep it real. It's the truth.
Yeah. Man,
part of us being afraid to tell the truth is giving into this thing. So don't do that.
Yeah.
Yeah, in medical school, I mean, even the process of going to medical school, they beat all of the hubris out of you. I think, you know, they just whittle us down. Yes. And so it makes us really afraid to even stand up for ourselves when what we're saying is based on truth and fact. And so, yeah, physicians have been villainized, and we need to definitely reverse that. As I said, I had a conversation with my physician assistant. I said, listen, we're talking about this. We have a very good working relationship, and I am very, very happy to be working with her. She's excellent. But at the same time, it is, we know I am the board certified dermatologist. She is a physician assistant. She has no problems with that. And so I don't want to throw the baby out with the bathwater, because I'm sure for those of us that need those people in our offices and we have good working relationships with them, we appreciate the care that they provide to our patients. But again, things are changing. Things are changing. And so it beckons us to come to the table and have a discussion about where we're going to go from here, because it can get very, very dangerous for patients.
I wonder if we should give like more rope, right? Not really for them to hang themselves. That's so negative. But this is what I mean. Do you remember when nurse practitioners or midwives were able to practice independently? And then hospitals were able to see, when looking at the data, that their lawsuits and complications and errors skyrocketed, medical errors skyrocketed. And then hospitals switched to it where they would not give privileges to a midwife who was not under the supervision of an OBGYN, is what happened. So now they've shifted back to being connected with the OBGYN. I wonder if this runs its course, then that might happen. However, we're not in the hospital, so I don't know what larger board would be the one that would see the data, and then allow it to correct itself. I don't know if derm would fall under the, fall into that same path where the data makes it where they have to end up coming under our wing again.
And that is what a lot of people are advocating for. They're sort of like, I'm not going to fight this, everything will come out in the wash. Just give them what they want, and we'll see what happens.
Right.
But we have our altruistic nature as a physician that says, but I don't want all of these patients harmed in the meantime. We're doing an experiment. This is also why a lot of people are advocating for truth in advertising laws, so that things are clearly stated. And they are saying, hey, the people need to educate themselves, and then the people can decide who they want their clinician to be. If they're comfortable seeing a nurse practitioner or a physician assistant, or they're demanding a physician, let the patient decide. But it's very hard to let the patient decide when the patient, number one, doesn't know who everybody in their white coat is, and doesn't understand the differences in the training. So if we're going to do that, then we have to be really, really intentional about educating the public on the differences. And the people who are profiting and benefiting from having, supervising 5, 7, 10, physician assistants, or running these clinics with all of these nurse practitioners and physician assistants, of course, they're not going to like that too much. But these are some of the suggestions that people have. They say, hey, just give it to them, and we'll see what happens. One of the studies that the nurse practitioners really use to sort of demonstrate that their care is equivalent to physicians was a study that was done a while ago. I think it was probably, 15, maybe even 20 years old. And this study is the most cited study that they have. But when we really delve into the study, there are a lot of biases, and there are a lot of problems with the study, which no one previously had called out until recently, even though this study is cited over and over and over again. And even sort of the founding mothers of nurse practitioners have made comments that they are concerned about the overwhelming number of online schools for nurse practitioners and advanced degrees. I know you see them, there are Facebook ads for them. And one of the issues is that when we were talking about giving nurse practitioners sort of more independence, these were better trained nurse practitioners. They often had 8 to 10 years experience as registered nurses. And then they went on to, you know, have semi-residency programs where they were training with residents for 9, 10 months. And then they were using a primary care role. But a lot of the nurse practitioners that are coming out have little to no clinical experience. We're talking 500-600 hours of shadowing. I've hosted a nurse practitioner in my dermatology clinic. This is before kind of this full practice authority was really getting going. And literally she just shadowed me. I think I let her go into a room to see one patient. And the patient almost wrote us a bad review because she was upset about the encounter. I'm not making this up. I'm literally not making this up. So if we're to say that she's going to go on and graduate and then potentially open up a dermatology office, and that's what some states allow, then we have a serious problem here. So we really, really, as physicians, need to be more vocal, and we have to find a way to do it that's not going to look like ego and money are our motivations.
It's always patient safety. And that's what we led with down here when we protected patients recently. Your story, the little anecdote that you just shared rings very true. I had my nurse practitioner who we're the same age. She's been a nurse practitioner as long as I've been a physician. She's actually been in derm longer than I have. We practiced at a previous practice. She has no interest in anything cosmetic, and I trust her because she knows when to come to me and, you know, whatever. She does these things where she will let nurse practitioner students shadow. She had a student that was shadowing. The woman came to me, wanted to shadow me for cosmetics. I said, absolutely not. I only deal with medical, like residents. I don't let anybody else shadow me. Residents only. She came as a patient. I did her lips. I did her Botox. She wanted me to like give her more information on how to do lips. I told her no. You know what her first job out of nurse practitioner school was going to be? A med spa doing lips, when she was 2 weeks before asking me how to do it. And guess what state? One guess, everybody.
Florida.
Florida! Of course. Of course it was Florida.
Yeah. Oh, it is. I have two comments. First is it's very person dependent. The practice I was at before had a nurse practitioner and a physician assistant, and I thought it was very appropriate the way that they saw patients, and they knew their limitations when they needed to go to the doctor, and they did that without hesitation. So it's very just person dependent, that's hard to regulate. But the other comment, going back to Dr. Kindred's comment on like the data, there were some studies I remember like reviewing in Journal Club during residency not that long ago from JAMA Dermatology, looking at, it's hard to look at objective things, but they were looking at like the number of biopsies needed to diagnose a skin cancer and then to diagnose a melanoma. And it was, I'm like thinking of, I mean, just this is off memory, so it could be off, but it was something like 20 something biopsies to find one melanoma for a mid-level. And then it was like 7 or 8 biopsies for a dermatologist for every melanoma they found, something like that. So it was just that way to look at objective data on differences in care. But that's a really hard thing to measure, of course. And then the people who are doing research are mostly in academic centers where there's probably not that many mid-levels being used.
Oh, don't say that.
Is that not true? No? Okay. Well, we didn't have any. So I guess I don't have experience doing residency with mid-level providers, but it just seems like the private practice world that's not really doing as much research, or not doing as much research, is where most mid-levels seem to be. So how do you track that, or give any data on differences in care? I know that because I was in Alabama last year and I still get the Alabama Derm Society emails, and they were asking for anecdotes of like times when it was dangerous for a mid-level to have, unsupervised practice or whatnot. So it's all a lot of just anecdotal evidence for some of our, but it's really hard to prove, you know, that when and if patients need a board certified dermatologist versus when is it okay for a mid-level to be in charge. So that's tough.
Yeah. Yeah, it is very tough. It's tough to count. Unfortunately, more and more our academic institutions are sort of giving the mid-levels a little bit more independence. And I really feel like those areas really need to be protected, especially for the residents and residency training. But yes, I recall the studies that you're talking about there. And the problem is, you know, all of the I would say all the conversations that say that nurse practitioners and physician assistants, you know, they help with healthcare, decrease healthcare costs. But if they're ordering more tests and doing more unnecessary biopsies, then they actually cost the system more. And that's something that people are trying to prove. But also, if something is missed and it leads to a worse outcome, then that's going to cost the system more as well. So we really do need some more data. I mean, it should be obvious that the longer you train and the more supervised and structured curriculum and certification and more hurdles that you have to jump as far as training and certification, that, you know, the level of care is not going to be equivalent. I don't know why we accept that for so many other fields, you know, but in medicine, what is super important, healthcare, we're not quite getting that message across. And I think it goes to the fact that doctors have been villainized and we're seen as, you know, people who we're in and out too quick. You know, we don't spend time with our patients, irrespective of if we get the diagnosis and the treatment correct, but we're not spending time with them. So patients don't really feel satisfied. They don't feel like we're spending time with them. So that plays a lot into the, you know, heart of a nurse type narrative that gets thrown around there. So the other question I wanted to ask, and I know we're kind of winding down on time, but, you know, even some of our academic institutions have started these residency and fellowship programs for physician assistants and nurse practitioners. And they're saying, we don't want them, you know, to leave school and then go out and provide care. So we're going to develop these programs. And then they're muddying the waters by calling them residencies. And so now what, a nurse practitioner may be residency trained at, you know, some of our more prestigious institutions. How is that going to ring on to the ear of a patient if they see that, you know, well, now, you know, I'm certified, or, you know, I did a fellowship at, you know, Hopkins or Yale. So what are your thoughts on these fellowship programs? There's some pluses and minuses there. Some people are saying, yeah, give them some training. So they're going to go out there and practice anyway. Maybe we should train them. So what are you guys' thoughts about that?
No.
I'm with Corey. No.
I'm also with Corey. No, and I had no idea that that was happening.
It's scary out here, y'all.
That's what I'm saying.
I'm
glad you guys are learning about things that are going on, because they are happening. And while we are chugging away in clinic, there are people who are lobbying, they're pushing for these things. And, you know, despite how we may feel about, you know, groups like AMA, they are trying to fight back. So we really need to be more involved, because while we're sleeping, you know, they're scope creeping.
I'm going to start using the hashtag scope creepers.
I mean, there's got to be a money grab too, because I mean, that's just.
It's always a money grab. Listen, so we heard that that group down here in Alabama had dermatologists who were willing to go and speak on their behalf in front of the board, and we were like, okay, who is it? Like, we did a witch hunt. Like, who is it? And come to find out, it was one guy who's a part of a big group here they're opening a downtown like spa injection clinic location that was gonna, I guess, hire PAs to just do that. And another one doesn't even practice in Alabama. He has an Alabama license. Again, what state does he practice in? Florida. And they were, and I'm not going to say the name, but you're going to be able to figure it out when I talk about who it is, because the feds were investigating this PA mill for years. So, I mean, you know, it's always follow the money. And then it made a lot more sense to us. Luckily, we were able to shoot that down. But, you know, Alabama's a dinosaur.
I love it. So we can't just say no. We really need to start engaging with our local derm societies, and even the Skin of Color. We need to start advocating. We really need to pressure our groups to do more advocacy so we can, you know, make our voice and our stands heard, because it's really difficult when all of they're hearing is from these groups and, you know, these false equivalency studies and, you know, all the wonderful things and all the wonderful care that they provide. So we need to be more vocal. This is not the age where, you know, you go to medical school, you become a doctor and you're set. You know, that age has passed. We really, in order to protect our specialty, but more so to protect our patients, because we know that we're the best trained to do the job. And again, I am all for a team-based approach. I don't want this to come across as, you know, mid-level bashing in any way, shape, or form. I am for a team-based approach, and I think that with appropriate supervision, we can provide great care as a team. So the last thing that I wanted to talk about, and I know we had mentioned it earlier, you know, there are about 420 residency spots for dermatology. It consistently is one of the most competitive fields, and that's because we want to train more dermatologists than, well, people want to go into dermatology more than we have the spots to train them. But as we mentioned earlier, you know, we're not really meeting the needs of the patients because we have so few dermatologists. So, you know, what are some suggestions we have, especially for our patients with skin of color? You know, if we talk about just a few dermatologists, you know, there are only a handful of us, and patients want to see us. And so this is an area where I think nurse practitioners and physician assistants of color who specialize in skin of color have really started to carve out an area for themselves, because they know that our skin of color patients are seeking that. And so maybe, you know, they prefer to see a Black nurse practitioner, or they prefer to see, you know, a Hispanic physician assistant rather than seeing, you know, a white dermatologist. So talk to me about, you know, what we can do as far as, do we need to increase residency slots? You know, how can we train more dermatologists? How can we meet that need, especially when it comes to our patients with skin of color?
So this is Shoshana. I don't think we need to reinvent the wheel. Dermatology is one of the only specialties where primary care is absolutely clueless about, right? Cardiologists are not treating run-of-the-mill hypertension. That was diagnosed by the primary care doctor, managed by the primary care doctor, and pediatricians don't know how to treat run-of-the-mill atopic dermatitis. So I would propose, before we skip over our colleagues with treating basic dermatology 101, that we have to beef up competency in dermatology and primary care. Yes, we like low-hanging fruit, but there's no reason why primary care isn't allowed to at least start a patient on tretinoin. And so long as we make it where our colleagues are clueless on derm, it leaves a huge, wide argument for mid-levels to say, well, patients need us, right? And there are MDs out there that could have taken care of some of this.
I'm with you 100%. I spent a lot of my time before moving to this area educating other specialists that have their sort of the first point of contact. I really enjoy that. So lecturing to, you know, internal medicine colleagues and emergency medicine physicians, as well as family medicine physicians. I really enjoy teaching them some basic dermatology, because I know they have a lot on their plate, but some of them do enjoy doing some basic dermatology. So I agree with you 100%. We need to first turn to our physician colleagues and empower them and teach them. I agree with you. Other thoughts?
I definitely feel like there has to be more pushback from physicians stopping the mid-level encroachment. I mean, it's like they've kind of figured out how to become doctors without going to med school and doing residency. And I think that that's going to be even more true once they start making everybody that's an NP have a DNP. So they'll be referring to themselves as doctors. Their colleagues will be referring to them as doctors, but they're not going to be physicians. And so I feel like there just has to be like a hard line where we're like no more. Like it just doesn't make sense after a certain point. And I think that that actually would extend to all specialties across medicine. Because I mean, how long until, you know, these mid-level providers are doing surgeries just by themselves? It's got to stop.
Any other comments? Yeah. Any other comments? We're winding down here. I did not hear from one physician assistant or nurse practitioner. I'm very disappointed. If you want to drop something in the chat, please do so. We do record these. So this, if you join late and you want to get the beginning of the conversation, you can go online. I want to encourage everyone here, if you're not already a part of the Skin of Color Society, there is a link in the chat box. So please click that and become an official member. It's really, really important. Don't just sit on the outside and enjoy our networking chats. Please join Skin of Color Society. We have a lot to offer. And last but not least, I wanted to put a plug in for Dr. Hope Mitchell, who's going to be hosting our next networking session. She's going to be talking about the influence of social media on dermatology, which is another hot topic. And that's going to take place on Thursday, November the 19th at 7 p.m. So please, please, please join us next time, November 19th. Dr. Hope Mitchell talking about the influence of social media on dermatology. You and your friends, please join the Skin of Color Society.
Hot topics. I want to congratulate and just acknowledge you, Dr. Fry, for moderating in such an excellent, outstanding way. Thank you very much. And yeah, everybody please join us when Dr. Hope Mitchell takes over for the next one. And then hopefully next year we can start doing this more in person. But I think that we've had a good group of sessions here virtually, and that will take us to 2021 when we will be able to hopefully get back to in-person meetings and cocktails and all that good stuff. So thanks a lot, guys.
All right. Have a good night, everyone.